Thank you, Dr. Khan. Good morning. In the 1970s, Balfour Mount was a surgical oncologist practicing at the Royal Victoria Hospital in Montreal, Canada. He was requested by his church at the time, the United Methodist Church, to arrange a seminar for physicians regarding Elizabeth Kubler-Ross's book on death and dying. So the seminar was to talk about patient experiences during their episodes of death and dying. And he found out that a lot of the physicians and a lot of the patients reported that patients had unmet needs, were left in pain on their deathbed. So what he did was he went back to his hospital, Royal Victoria Hospital, and said, let's look at the experience of these patients here at our hospital. He was shocked to find out that a lot of the patients were left in pain, psychological pain, physical pain, and had to suffer unnecessarily. So he went to the St. Christopher's Hospice in London and trained under Dame Cicely Saunders, who was the founder of the hospice movement, came back to Royal Victoria Hospital and founded the first palliative care unit in North America. So Dr. Balfour Mount, who's a surgical oncologist, is actually the father of palliative care in North America. So palliative care actually is deeply rooted in oncology. In fact, in palliative surgery, 21% of surgical procedures for cancer patients are palliative in nature, with the goals of being symptom relief, symptom avoidance, preservation of independence and function, reduction of hospitalizations, and improvement in quality of life. And if you look at this is really the battle cry of palliative care as a subspecialty, because it is all about making patients feel better. There are 8 identified causes of suffering: physical suffering, disease suffering, pain, psychological and existential suffering, depression, anxiety, fears about the illness, fears about the future of the illness, social issues, spiritual issues, why is this happening to me, meaningful issues, meaningful existence, practical issues, just going to the bathroom, cooking for themselves, end-of-life management, and grieving and loss. And these causes of suffering are echoed by the 8 domains of palliative care as introduced by the National Quality Forum and the National Consensus Project for Palliative Care. So the growth of palliative care has been very exponential within the last decade. In fact, more than 90% of hospitals with more than 300 beds have an identified palliative care team. And the growth of the subspecialty, although relatively new, has also been exponential within the past 10 years. In 2006, it was approved by the American Board of Medical Subspecialties as a subspecialty, and there were 10 co-sponsoring boards who could sit for the exam. The first exam was in 2008, and as of 2012, though, the grandfathering period ended, and only physicians who have completed a palliative care fellowship are able to sit for the boards. Unfortunately, there's very few palliative care fellowship programs across the country. There's only 85, generating 234 positions per year. But the growth of palliative care has been spurred by the acceptance and the recognition that the family should be the unit of care, that the patient should not be treated in isolation. In addition, diseases that we once thought would cause rapid acute decline are now more chronic in nature, with patients surviving, living years, living more than their prognosis, and actually, as Dr. Soma said, living longer than expected. But the biggest development in the field of palliative care is the acceptance that the relief of suffering, open, honest communication, goal-directed care, and a whole-person approach is as important as cure. So there have been several agencies that have spurred the development of palliative care. The primary one is the Center to Advance Palliative Care, which has really helped in program development across the country. This is for hospitals, both inpatient and outpatient programs. The National Palliative Care Research Center is spearheading the research arm of palliative care to try and develop these randomized controlled trials that will help in symptom management, that will help in quality of life. And we actually have clinical practice guidelines from the National Quality Quality Forum in the National Consensus Project, saying that there are 38 quality measures for a quality palliative care outcome. And JCAHO has introduced advanced certification for palliative care in 2011, and as of recently, there have been between 40 to 50 hospitals certified in palliative care, with a hope of more to come. So this dichotomous care model, where palliative care and hospice are introduced only when there is nothing left to do, is a care model that should not even be practiced anymore. In fact, ASCO, the American Society of Clinical Oncology, released a provisional clinical opinion in 2012 stating that palliative care, early and integrated with complementary oncologic therapy, has proven good outcomes in terms of quality of life, mood, survival benefit, and symptom management. In the integrated model, palliative care is introduced at or around the time of diagnosis, with involvement increasing as the role of life-prolonging therapy decreases. In addition, palliative care is trying to separate itself from hospice, from which it was developed under, so that patients have access to palliative care even when they do not have that 6-month prognosis hanging over their head. So palliative care should really be not diagnosis dependent. It is not prognosis dependent. It is interdisciplinary, requiring the help of the physician, the primary care physician, the subspecialist, the nurses, the case managers, the physical therapists. It's complementary, and it focuses on an expanded unit of care. Now, when you look at the scope of palliative care, the scope of palliative care includes symptom assessment and management, illness understanding and education, medically appropriate patient-centered goal setting, and psychosocial support for the illness. And if you look at these 4 bullet points, you'd realize that these are the same skills that every physician should have and that every patient should have access to. So why do you even need a subspecialty palliative care involvement? Who among your patients would benefit from the role of palliative care? So the National Comprehensive Cancer Network produced a screening and referral tool for palliative care patients, but it was very extensive. But Dr. Glair at Memorial Sloan Kettering actually trialed the NCCN screening tool, and although this is a very busy slide, it does show that it includes the presence of metastatic or locally advanced cancer, an ECOG functional status score that is low, the presence of one or more serious complications of advanced cancer, serious comorbidities, and presence of palliative care problems, which were identified as uncontrolled symptoms based on standard approaches, moderate to severe distress in the patient or the family, concerns about disease course and decision-making, a request for a palliative care consult, and the team needing assistance with complex decision-making or determining goals of care. A score of 5 out of 13 generated a palliative care consult. What he found, though, was that if you did a blanket referral for all these cancer patients, it was time-intensive, it was exhausted, and it was not very efficient. So the actual consult triggers for these cancer patients should be complex symptom management, somebody who may need more pain medications, who may need opioid rotation, who may already be having opioid toxicity and would need a rotation to some other medication or a rotation to methadone. Complex depression, existential grief, spiritual distress, or multifaceted distress, which is not necessarily treated by the palliative care physician, but is treated by the complementary team, meaning the social worker or the case manager or whoever may be required. Care of the complex, severely ill patients over time. So these are the new patients who may be diagnosed with metastatic cancer at the onset of diagnosis and have excessive symptom burden, whether it's pain or nausea or vomiting or depression or shortness of breath. Frequent admissions for the same diagnosis. These are the patients that you see over and over coming into the hospital for the same diagnosis within a very short, within a short amount of time. Patients who are admitted to the ICU with metastatic cancer who may need to readdress goals of care. Assistance with medical decision-making and goals of care. And I'd like to point out here, redefining hope in the setting of serious illness. It's a big misconception that the involvement of palliative care denies patients of hope or makes them lose hope. In fact, it's a way or it's a forum for patients and families to redefine hope in a serious illness, to figure and use hope as a verb and not as a noun. And issues regarding future planning needs. Most commonly, we see this in dementia patients who get palliative care involvement because there are questions in artificial feeding and hydration, questions because TPN has been broached or that the family has been approached for a PEG tube or PEG feeding. So although there are few randomized controlled trials in palliative care, they do exist. This is 5 out of the 7 common randomized controlled trials that are frequently mentioned in literature. And of these randomized controlled trials, 4 are actually outpatient-based trials, and 1 is an inpatient-based intervention. These trials show an improvement in the quality of life, improvement in mood, symptom burden, diminished caregiver distress, increased documentation of care preferences, and an improvement in survival. 2 trials, the Project Enable 2 and the TEMEL study coming out of Massachusetts General Hospital, showed an improvement in survival, although it is still debatable. The question is, why can these patients, or why do these patients appear to be living longer? And the realization was that because the focus of palliative care is illness understanding and prognosis understanding, although we really don't know much about determining the prognosis of these patients, but because it's illness understanding, these patients and families understand their illness, understand the realities of their disease, have better coping support, have better symptom management, and are thus able to make better choices in terms of their end-of-life issues or in terms of their future direction of care. So there are also economic outcomes in palliative care. There has been shown a decrease in resource utilization, decrease in length of stays, particularly in the ICU, and cost avoidance. But more importantly, palliative care is not really about saving patients money or saving the system money, because these do not affect the quality of care or increase morbidity or mortality. It really is all about good care. It's not just about saving the system. But in this study, though, this came out from the Palliative Care Leadership Center, where they summarized data from 5 large academic institutions with palliative care programs. And at the day, or on the day of palliative care consult, right after, you will see a significant decrease in cost for these patients. So several states have also recognized the importance of palliative care. New York, California, Massachusetts, Rhode Island, New Hampshire, Connecticut, they all have state-sponsored initiatives promoting palliative care. And these include the need for advisory councils or the need for web resources for patients and physicians alike, pilot programs for data collection, and increased access to palliative care. But how is palliative care accessed? The most common access point for palliative care is the inpatient consult service, where you have a roving consult service, the floors or the emergency room or in the intensive care unit. And in larger academic centers, there are 3 to 24 bed non-hospice inpatient units, primarily for symptom management. The future of palliative care is really the outpatient model, where you're able to develop a longitudinal relationship for symptom control and psychosocial support. And in this outpatient model, 90 to 95% of these palliative care clinics are co-located or embedded in cancer centers, thus promoting timely transitions from a palliative care / oncology approach to a primarily palliative care or maybe even a hospice transition. The inpatient palliative care encounter, the initial palliative care encounter includes symptom assessment and management, evaluation of patient and family coping, and illness understanding. Another misconception is that in the initial encounter, that the palliative care team starts talking to the patient and the family about accepting death. But in this study from Massachusetts General Hospital, where they actually looked into every inpatient encounter for a significant number of patients, transitions of care are not discussed at the onset of the consult, nor is advanced care planning or establishing goals of care. The initial and even the secondary meetings are really about rapport building, determining how these patients make decisions, how family support is done, and how much more do these patients need in terms of help. So there's a lot of barriers to palliative care. Most commonly is the research barrier. Because of the very ill population, there's the sickest of the sick, there's a high attrition rate, so that some studies actually lack power in detecting statistically significant data. There's also ethics involved because, again, they are seriously ill. Then there's a question of the burden or the benefit of doing interventions with unproven benefit when the main focus should really be on comfort. And the outcome measures as well. Do you measure survival? Do you measure an improvement in mood? Do you measure their symptom burden? The clinical barriers are significant. The scope of palliative care, the identity crisis that palliative care has, is actually the focus of the American Academy of Hospice and Palliative Medicine right now, where palliative care is trying to get farther away from hospice and redefining itself so that you could provide care to patients who, again, do not have that 6-month hospice prognosis. Access and delivery is a problem because there's not enough palliative care professionals to man the palliative care clinics or to do the inpatient consults across the states, particularly if there are state-sponsored initiatives requiring that as in Rhode Island, that every local healthcare organization has palliative care access. And then you have practice perspectives in terms of differing physician opinions as to who needs palliative care and the measure of success. So moving upstream, the goal of palliative care as a specialty is really to fix the identity problem, to reform medical education. Now, oncology fellows, surgery residents, medical residents, they are required to do palliative care rotations, and they do have seminars now in terms of communication, how to break bad news, how to disclose prognosis. The randomized controlled trial evidence base is also being developed, especially in an era where if it's not measured, it does not exist. And there's an attempt to expand outside the hospital setting because in the inpatient setting, every inpatient consult is usually a crisis situation, whereas the outpatient consult is really the model where you get to know the patient and their families and are able to assist them in decision-making or symptom management. Collaboration with multiple specialties, particularly oncology, is very important. As of now, there are several guidelines, heart failure guidelines, COPD, multiple sclerosis, and end-stage renal disease that have embraced early integration of palliative care into standard medical care. Again, we try to encourage federal and state-sponsored initiatives and maybe down the road even payer incentive changes where a meeting or a 30 or an hour talk with a patient about advanced care planning or about goals of care is reimbursed as well as somebody who would be doing a procedure, because it is a procedure, communication and talking about end-of-life issues or advanced directives. But the areas of collaboration for us now is really in terms of symptom control, managing patients and families' distress, complex decisions, and negotiating through critical illness. Because even if we approach these patients and families from different perspectives and from different specialties, from the nursing perspective or from the pharmacy perspective, we all have a common goal, and Eric Cassell, who's a physician and the author of the book, The Nature of Suffering, says that the relief of suffering and the cure of disease must be seen as twin obligations of a medical profession truly dedicated to the care of the sick. Our failure to understand the nature of suffering can result in medical interventions that, although they are technically adequate, not only fails to relieve suffering, but becomes a source of suffering itself. And these are some websites on palliative care. Thank you.